Now we are moving on to chapter 9, talking about the joints. These photos are from a trip I took a couple years ago. On the left, this is Bryce Canyon in Utah, and on the right is Zion National Park. Gorgeous places to visit if you ever get a chance. So at the end of this chapter, your learning goals are going to be to contrast the major structural and functional categories of our joints and be able to give an example of each of these categories, and also to describe the relationship between joint strength and joint mobility. You need to describe the basic structure of a synovial joint, the accessory structures and what their purpose is. And then give us some examples of how joints are injured, know the common ways that joints can be injured, and describe what happens if the circulation of synovial fluid in a joint is disrupted. You need to identify the type and range of motion that we find at synovial joints and classify those joints based on their movement. You need to describe the location, structure, and function of our intervertebral discs and understand what's happening when a disc herniates. You need to have a general idea of the anatomy of the knee, shoulder, and hip joint, as well as common injuries that can occur here. You need to know which of our joints between the shoulder and hip has the more limited range of motion and why, and describe some different forms of arthritis that can affect our joints. So what is a joint? A joint, also known as an articulation, is basically where two bones meet. And this is a spot in our body where movement is going to occur. And when we have joints, there is a trade-off between strength and mobility. The stronger a joint is, the less mobility that we're going to have at that joint, and vice versa. The more mobility, the less strength we will have at that joint. When we're looking at joints, we have two classification schemes. We talk about the structural classification, meaning the anatomy itself of the joint, and we have four major structural categories: fibrous, cartilaginous, bony, and synovial joints. And then we also have our functional classification scheme, which has to do with those ranges of motion. We have three major categories in the functional scheme. We have synarthrosis. Those are joints that are not movable, and we primarily see those in the axial skeleton. We have amphiarthrosis. Those are joints that are slightly movable, also primarily in the axial skeleton. And then we have diarthrosis, and those are our freely movable joints, primarily found in the appendicular skeleton. And the structure of a joint is going to determine its function, much like the rest of anatomy. So let's talk first about one of the functional categories of joints, the synarthrosis. So remember, functional means the amount of movement that we can see in this area. So the synarthrotic joints are the immovable joints. And remember, we have that inverse relationship between mobility and strength. So if we have an immovable joint, it's going to be a very strong joint. And that's why we find these joints located where movement needs to be prevented. The edges of the bone may actually touch or interlock like a puzzle, and we can have a fibrous or cartilaginous connection there. Over time, some of them actually may fuse or ossify and form a bony joint. There are four structural classifications of synarthrotic joints. Remember, structural is talking about the anatomy. So we have the suture joints, the gymphosis, synchondrosis, and synostosis. So let's go through the different structural joints within the category of the synarthrotic joints. So, suture joint. Suture joints are found only between the bones of the skull. And with these joints, those edges of the bone interlock and are bound by dense fibrous connective tissue. And sometimes, remember, we had little tiny puzzle piece bones that were found along those suture lines. Quiz yourself and see if you can remember what those were called. Thought it was going to pop up here. There we go. Those are called Wormian bones or sutural bones. Then we have our gomphosis. So this is the joint that binds our teeth into the bony socket. And think about, quiz yourself here again. Which bones of the skull are the teeth bound to? Let's see if they'll pop up for me. There we go, our mandible and maxilla. And then this joint provides a fibrous connection between the tooth and the socket. And the name of that fibrous connection is the periodontal ligament. And I'm going to try and see if my pen is going to work here. I guess not. Come on. All right, sorry. I had a fancy new pen, but it's not working. So I'm going to have to use my finger. So in this image, on the right, or in the middle, I guess, of your page, we've got our tooth here. And then this kind of tan area or ivory colored area is the bone. That would be either the mandible or maxilla. And then this pink area between, let's see, I'll highlight it in purple. Here, this is actually a ligament that's connecting that tooth to the mandible or maxilla, and that's called the periodontal ligament. And if you have ever had to have a tooth removed, that often involves stretching of the periodontal ligament. In dogs and cats, we do have to remove their teeth from time to time. And one of the things that we have to do when we do this so we don't cause trauma is we stick what's called a dental elevator, which looks kind of like a long metal probe down in this area in between the tooth and the mandible or maxilla, and kind of apply a steady pressure. And the purpose of that is to stretch that periodontal ligament, that connection to the mandible or maxilla, so that we can remove that tooth. Then we have our synchondrosis. The synchondrosis is a rigid cartilaginous bridge between two bones. In places we find this is between the first vertebrosternal ribs and the manubrium of the sternum. And you can see that here in the picture on the right. So here is the manubrium, and these are our first vertebrosternal ribs, and in blue is that synchondrosis, that connection between those two, fibrous connection, cartilaginous connection. And then we can also find it in the epiphyseal cartilage of our growing long bones. Remember how our long bones grow in length. That interstitial growth happens at the epiphyseal plates, which are cartilage. Remember, the cartilage is growing, the osteoblasts are chasing behind it to allow growth in length. And so this cartilage of the plate is actually a synchondrosis, a joint. Then we have a synostosis. A synostosis is when we have two bones that actually fuse completely and become totally immobile, and the boundary between these bones then disappears. Examples of where we would find these, we have fusion of the right and left mandibular bones. Initially, when your bones are forming, the mandible is a right and a left side, but they do fuse completely, forming that synostosis. The epiphyseal line of our maturing long bones. Remember, we were just talking about that epiphyseal plate in the last slide that was cartilage. Remember, eventually those osteoblasts start becoming more active than the cartilage cells and catch up, and that cartilage disappears, and we're left behind with that epiphyseal line. And that would be a synostosis as well. There are also, in rare instances, there can be a synostosis of the frontal bone. Normally the frontal bone is just one solid bone during development, but sometimes it can actually be two bones. And then we get this suture that ends up completely fusing and becoming one frontal bone, and that is another example of synostosis. So those were our synarthrosis, our immobile joints. Now we're going to move to the functional category of amphiarthrosis. These joints allow some movement. They're more movable than that synarthrosis, but they still allow only a limited amount of movement. So they are, in terms of strength, they're a little weaker than the synarthrosis, but stronger than the diarthrosis, which are freely movable joints. These joints are usually a fibrous or cartilaginous joint, and we have two different structural types of amphiarthrosis. We have a syndesmosis, in which bones are connected by a ligament, and the example of this is the distal joint between your tibia and fibula in your leg, and that's what's pictured here in this image. So we've got your fibula and tibia, and there's this ligamentous connection between those two. So that is a syndesmosis. Then we also have a symphysis, and with the symphysis, the bones are connected by a wedge or pad of fibrocartilage, and an example of this is the pubic symphysis, which you can see in the image on the right. So those are our amphiarthrosis, allow for a very limited amount of movement. So now we're moving on to our last functional category, and that's our diarthrosis. So our diarthrosis are our freely movable joints. These joints have the most amount of movement, which means they're also going to be the weakest in strength. The movements in these joints can be classified in multiple ways. We can have monoaxial movement, which means movement in one plane. So for example, our elbow, when you move this is going to be hard for me during this lecture because I'm very bad at figuring out where the camera is recording. So if we move our elbow, we can really only move it in one plane, monoaxial. You might think you can move it this way, but this isn't actually your elbow moving. So if you hold your elbow firmly in place, you really are only able to move it in one plane. We have our biaxial, which means we can move in two planes. An example of that would be our wrist. So we can move our wrist this way and this way. And then triaxial means three planes, and that's going to be our shoulder and hip. So our shoulder and hip allow the most amount of movement. We can move our shoulder and hip in all directions. We find these joints, these diarthrosis, at the ends of our long bones. We have accessory structures that help stabilize them. Remember, we've got a lot of movement here, so the joint's going to be weaker. So we want to have these accessory structures to stabilize them. So when we talk about structural categories of diarthroses, we really only have one structural category, and that's our synovial joints. The synovial joints have a joint capsule or articular capsule that surrounds the joint, and you can see that in the picture here on the right, it represented in blue. So we've got this joint capsule that surrounds. And within this joint capsule, we have a special membrane. Think back and see if you can remember what membrane we talked about in the last unit that we might find here. So that would be the synovial membrane. And this joint capsule is continuous with what on the bone? Remember we talked about fibers kind of intermingling with something that covers the outside of the bone. And then actually those fibers extend actually into the bone. And that's going to be the periosteum. So you can see the periosteum here. So that joint capsule is continuous with that periosteum. The joint capsule has an outer fibrous layer and then that inner synovial membrane. The membrane is made up of areolar tissue and that incomplete epithelial layer. We talked a little bit about it in the last unit. And synovial fluid is going to be produced by that synovial membrane, by that areolar layer. And that synovial fluid is very important. It's going to fill that joint cavity. The synovial membrane does not cover the articular surface. The articular surface is covered by articular cartilage. So if we look in this image here, I'm just going to erase what I've drawn so far. So that blue on the outside was the joint capsule, but if you're looking at this picture, let's see, I'm going to draw in purple now. There's the synovial membrane itself is in pink. And that didn't show up very well. Let's try yellow. And I'm going to use the highlighter. See how this works. So here, hopefully you're seeing that on the right-hand side. Now I'm going to go on the left-hand side. Not working as great as I would want, but here on that inside of that joint capsule, you can see that synovial membrane. It's that thin pink line. So it lines the joint capsule and does cover a little bit of the bone, but the actual articular surfaces, meaning the ends of the bone that would be coming into contact with each other, are not covered by the synovial membrane. Those are covered by our cartilage. And what kind of cartilage covers the ends of long bones? Think back, quiz yourself. Remember how did we form these long bones, right? We started with a cartilaginous skeleton, and that cartilaginous skeleton was made of hyaline cartilage. So hyaline cartilage is going to be there at the articular surfaces. So that hyaline cartilage, that articular cartilage, covers those articulating surfaces, and this prevents direct contact between the bones. It is similar to the hyaline cartilage elsewhere in the body, but within the synovial joints, we do not have a perichondrium or that fibrous sheet covering the cartilage here. And the matrix of this cartilage in the synovial joint has more water than other cartilages. The surface of that cartilage is very slick and smooth, and the cartilages are separated by a layer of synovial fluid. So flowing within this, let's see, we'll do blue. Floating between these articular cartilages and on either side is actually synovial fluid that, remember, is produced by that synovial membrane. Damage can occur to this cartilage, and unfortunately that can impair joint function. The matrix of the cartilage itself can start to break down, and then exposed surfaces of the cartilage and eventually the bone can change to rough, abrasive surfaces, which is going to increase friction. So I mentioned that synovial fluid filled that area between the articular surfaces. That synovial fluid is clear and viscous, kind of has the consistency of egg yolk, and it contains proteoglycans and hyaluronan, which is secreted by the fibroblasts of the synovial membrane. It is a small amount of synovial fluid. For example, within our knee joint, we have less than 3 milliliters of synovial fluid. A teaspoon has 5 milliliters, so we've got less than a teaspoon of synovial fluid in that knee joint, but it is very important. Its primary function is lubrication. The cartilage there within that joint acts kind of like a sponge filled with synovial fluid. So we've got, picture your long bones on either end with this kind of cartilage sponge between them. And when the cartilage is compressed, so if the bones come together and kind of squeeze that cartilage sponge, some of the fluid gets squeezed out between those cartilages, between the opposing surfaces, and this helps reduce friction. Another function of the synovial fluid is distribution of nutrients. The fluid in that joint circulates continuously to provide nutrients and remove waste from chondrocytes within the avascular cartilage. Remember, cartilage was one of those tissues we talked about that's avascular, meaning it doesn't have blood vessels. So we need to find a different way to get nutrients in and out. So circulating that synovial fluid through the cartilage is important in keeping the cartilage healthy, bringing it nutrients and getting rid of wastes. So whenever that cartilage is compressed and released, remember it's kind of like a sponge, the synovial fluid is moving in and out and in and out of the matrix of the cartilage, circulating that fluid throughout it. And as fluid flows through the areolar tissue of the synovial membrane, more nutrients get delivered and wastes get absorbed across capillary walls there. The other function is shock absorption. The viscosity of the synovial fluid helps cushion from compression. As the pressure increases, the viscosity also increases, so it acts as a shock absorber. So remember I mentioned the synovial joints. Those are our freely mobile joints. More movement equals less strength. So we have these supporting accessory structures to try and provide some strength and stability with these synovial joints. And there are a couple different kinds of supporting structures. We have cartilages. A meniscus is a fibrocartilage pad between the opposing bones. An example of where we see this is within the knee, and you can see a picture here of the meniscus. So this is your knee, and we've got these fibrocartilaginous pads, and this is looking down from above, an anterior view of that the meniscus. Here's a meniscus, here's a meniscus. So this unfortunately is an area in the knee which is prone to injury. If you've ever had a meniscal tear, it can be quite painful. We also have fat pads. So we have masses of adipose tissue covered by synovial membrane, and these can be superficial to the joint capsule, which means on the outside, or they can be within the joint capsule themselves, and you can kind of see that in this image here of the elbow. We've got a fat pad here. These are superficial fat pads. And these fat pads are going to, remember, one of the functions of adipose tissue is to provide a cushion. So they're going to protect the articular cartilage. They also provide kind of a packing material for the joints. If the bones move, that fat pad is going to fill in the spaces that are created in the joint cavity. Then we have ligaments. Ligaments are localized bands of tough fibrous connective tissue. Remember, they're made up of that dense regular connective tissue, and they connect bone to bone or bone to cartilage. They provide support, strengthen, and reinforce our joints. And we can have extracapsular or intracapsular ligaments, meaning inside that joint capsule or outside that joint capsule. A sprain, if you've ever heard of someone spraining an ankle, a sprain occurs when that ligament has been stretched until the collagen fibers within that dense regular connective tissue start to tear. The ligament remains intact and the joint is not damaged, but we do have some tearing of the cartilage. Our bones actually heal more quickly and effectively than ligaments do. Why would that be? Think back to your differences between some of our tissues. Our bones have a huge vascular supply, right? The ligament has no direct blood supply, so it must obtain its nutrients via diffusion, so it is a tougher tissue to heal compared to bone. And then we have tendons. Tendons are not part of the joint, but they do help stabilize the joint. They connect the fleshy part of a muscle to the bone that makes the joint, and they can pass across or around a joint. They're going to help stabilize a joint, but do limit the mobility. Then we have our bursa. These are little thin pockets of synovial fluid within connective tissue. They're lined by a synovial membrane, which is producing that synovial fluid, and they may be connected to a joint cavity or they can be separate to a joint cavity. And these little I think of them kind of like a little water balloon of synovial fluid. They help reduce friction and act as a shock absorber. They're going to cushion areas where tendons or ligaments rub against other tissues. And we can sometimes have actually synovial tendon sheaths. So a synovial tendon sheath is like a tubular bursa that surrounds a tendon that's going to cross a bony surface so that that tendon is not rubbing directly up against that bony surface. This bursa, kind of like a little tubular water balloon, is going to surround it and provide some cushioning and shock absorption. We can find these bursa deep to skin that covers bone or within other connective tissue that's exposed to friction or pressure. And we can get these bursa that develop in abnormal locations that are not something that's naturally occurring because of abnormal stresses, and those are called adventitious bursa. So if for some reason, due to some activity we're doing or an injury, we are getting an abnormal stress in an area, our body might actually create this adventitious bursa to help kind of provide some cushioning. Bursitis, remember itis is a suffix indicating inflammation. So bursitis basically is an inflamed bursa. And when that bursa becomes inflamed, it actually swells with synovial fluid. And this can cause pain. It usually happens due to repetitive motion, that repetitive motion causing a high amount of friction, pressure over the joint, or we can have it due to trauma or infection. Examples of bursitis, we can get bursitis of the shoulder or elbow due to repetitive motions in athletes and musicians, golfers, pitchers, tennis players, or musicians such as violin players that are doing a repetitive motion with the shoulder or elbow can end up getting inflammation of the bursa. An example of pressure-related bursitis, there is a condition called a bunion, which is, you can see in this picture on the bottom right, where the great toe gets this, basically a distortion, an enlargement of the first metatarsophalangeal joint. So basically this bony joint here is enlarged and it causes an increased friction and pressure, and that can lead to bursitis in that area over that joint. And then this picture on the left is an example of bursitis that we might see in, for example, a tennis player. High-heeled or pony-toed shoes can be a cause for the pressure-related bursitis in the feet. So just keep that in mind when you're choosing your footwear. And this image is basically showing you the accessory structures of the knee joint, where we can see all of these accessory structures in one slide. So let's see, what color? We'll just do red. So we've got our meniscus here. Remember, those were those fibrocartilaginous pads. We have bursa, they're in green here. So these little synovial fluid-filled pockets. We have fat pads. We've got some within the joint, and we've got fat pads outside the joint. And then we're going to have ligaments Kind of hard to see here because it's cut in half, but that's a cruciate, one of the cruciate ligaments there. And then we have tendons connecting the muscle to the bone. So movement outside of a joint's normal range of motion. Sometimes you will see the abbreviation ROM, and that means range of motion, which basically is just the normal movement that a joint can perform. So if we move outside the normal range of motion, this can cause damage. Factors that help stabilize synovial joints and prevent injury by limiting the range of motion include the collagen fibers that are in our joint capsule and ligaments, the shapes of the articulating surfaces and those menisci, the actual shape of the bone or those meniscus, those cartilaginous pads, can actually kind of affect how the bones can move against each other. Other bones, muscles, or fat pads around the joint are also going to help stabilize. And then those tendons that attach to the articulating bones, attaching that muscle to the bone will also stabilize it. Our most mobile synovial joint is our shoulder. And so what does that mean? If it's our most mobile, it's also one of the ones that is most prone to injury. Dislocation or luxation occurs when the reinforcing structures around a joint can't protect from the extreme stress a joint is experiencing, and we end up with complete loss of contact between the articulating surfaces. So those bones that are normally in contact with each other are no longer in contact. They're no longer touching. We get complete loss of contact there. And when this happens, we can end up with damage to that articular cartilage, we can get ligaments that are torn, and the joint capsule itself can get distorted from that stretching. Inside the joint itself, there are not pain receptors, but there are nerves outside and around the capsule, the ligament, and the tendons, and these are very sensitive, and that's why joint dislocation can be very painful. I've been lucky enough, I have not dislocated any joints, but I have heard that a dislocated shoulder can be comparable to childbirth. So I have experienced that. So I would not like to experience a dislocated shoulder. Subluxation is basically a partial dislocation. So there is still some contact between those articulating surfaces, but not the normal amount. Let's talk about joint movement, ways our joints can move. So we already mentioned this term range of motion, ROM. Range of motion is the full movement that's allowable naturally at a particular joint. And we have different ranges of motion in different joints. Depending on the joint, the range of motion is going to be different. When we say range, we mean the distance between full flexion, which means a decreasing angle. So let's see here if I can figure out my camera. So if I'm looking, say, at my elbow, right? And this is the angle that I'm measuring. So flexion, we're decreasing that angle, right? And extension, we're increasing that angle. I need a little protractor from my 13-year-old. A limited range of motion means that joint cannot move through the normal range of movement. I actually have a joint with a limited range of motion. I demonstrate this normally in class when we're together, but it's probably harder to see on a camera. But I broke my arm multiple times, unfortunately. When I was a child, I was very clumsy. And so I, as a result of that, have a limited range of motion in my wrist. So just to give you an example, my right wrist, which was unaffected, I can turn, so all the way here. My left wrist, however, has a limited range of motion, and I can only turn my left wrist this far before it does a little pop, which you might be able to visualize here. And then that is the absolute farthest I can turn it. So due to previous trauma to that joint, I have a much limited range of motion compared to the other wrist joint. So just compare them again. So that's a limited range of motion. When we're describing movements in the joints, they're described in terms that reflect the plane or direction of the movement, as well as the relationship between the structures, the relationship between the articulating surfaces. And we talk about different planes of movement. We mentioned this before. We have monaxial, meaning movement in one plane. We had the example of the elbow there. So monaxial. Biaxial was the wrist. Two planes of movement. I am not good at knowing where my arms are in relation to this video camera. And then triaxial, 3 planes of movement. We can move our shoulder in multiple planes. So when we're talking about these planes of movement, we're talking about a lateral medial axis, an anterior posterior axis, and an inferior superior axis. And this slide is just giving you an idea of what we're talking about when we're talking about those different axes of motion, the lateral medial, inferior posterior, and superior inferior axis. So we have different types of movement at the synovial joints, and we're going to go through each of them. We have gliding movement, and that happens when 2 articular surfaces are sliding past each other. It's a small amount of movement in a gliding motion. We see this in the carpal or wrist bones, the tarsal or ankle bones, and the clavicles and sternum. So clavicles are a collarbone. Angular movement, that's flexion and extension, abduction and adduction. And when we're talking about these movements, we're describing the movements in relation to anatomical position. Remember, anatomical position is a person standing facing forward, arms at their sides, palms facing forward, right? So that's anatomical position. So we're describing motion in relation to someone who is standing in anatomical position moving. Circumduction is a complete circular movement. An example of this would be moving your arm in a circle if you're drawing a circle on a chalkboard. Rotational movement. We see this in rotation of the head and rotation of limbs. We can have medial or lateral rotation, pronation and supination, and then special movements. So let's go through each of these. Normally this is a fun lecture when we do it in person because I make everybody stand up and move around. So I would recommend, if you're doing this at home, to get up and actually do these movements while you are doing this lecture, because doing the motion sometimes can help cement it in your brain. This is also another spot where sometimes we play Simon Says in class and ask you to do certain movements using Simon Says. So if you have somebody else in your house, you can play that game with them as well. Your book gives this example of placing a pencil against a flat surface of paper to kind of help understand the way motion is happening. So if we hold, I'm going to use my phone instead of a piece of paper. If we hold the pencil upright and we just slide the pencil across the surface like this, this is what's called a gliding motion, and we can slide it from side to side or forward and back. So this gliding motion is a linear motion, and we can see this in movement in bones of the wrist, the carpal bones, bones of the ankle, the tarsal bones, and between the clavicle and sternum. And this movement can occur in many directions, right? We can make this pencil move in lots of different directions here. But the amount of movement is small, and rotation at that joint is prevented by the joint capsule and associated ligaments. So as I mentioned before, examples of where we might see this gliding movement: the carpal bones or bones of the wrist, the tarsal bones or bones of the ankle, and between the clavicle and sternum. Now, if we take that pencil and we keep the tip held in that same spot, but we move it side to side, this is showing you an angular motion. So we're either increasing or decreasing the angle of the pencil in relation to the phone or the piece of paper. So examples of angular movement, flexion and extension are movements in the anterior posterior plane in relation to that anatomical position. So flexion is going to be decreasing the angle between our articulating bones. So the example in this image of flexion is seen right here. So flexion, here we go again. If I'm standing in anatomical position, when I'm flexing, I'm making this angle here between these articulating bones decrease as I flex. Whereas extension, I'm going to be increasing that angle between those articulating bones. So that's extension. And extension can be seen here in this image. Oops. The long bones in the limbs are where we see this, and also in the axial skeleton within the neck. So flexion and extension of the neck, flexion, extension of the neck, as well as we can have flexion of the spine. Think about bending down and touching your toes. When we're standing in anatomical position, all our major joints at that point are at full extension. So stand in anatomical position, all of your joints are at full extension except for your ankle. That's the one exception. Hyperextension is when you extend or increase that angle past normal anatomical position. So for example, if I'm sitting here, my neck right now is at an anatomical position at full extension. If I bend my head backwards, then that is hyperextension. I'm going past that normal anatomical position. You can also see this example in this image here on the right-hand side. So normal anatomical position would be this hand going straight down, flexion, hyperextension. The other form of angular movement is abduction and adduction. And these are movements away from or towards the longitudinal axis or midline of the body in the frontal plane. So abduction is moving away from the longitudinal axis. I don't have very much room here to stand back. So here's my longitudinal axis. Abduction, moving my limb away from the longitudinal axis. Adduction would be moving towards the longitudinal axis, and I can do that with my leg too. You probably can't see. Abduction, adduction. And the way that you can remember which is which is that abduction, when someone is abducted, they're taken away. And with adduction, the limb is added towards the body. And we can even see this in the hand in relation to the central digit. So if we have the central digit as our midline, we're abducting if we spread our fingers apart because we're taking them away from the midline, and adducting, adding them back towards the midline if we bring them back in. With circumduction, we have a more complex angle. So if we place our pencil directly on, we don't move the tip of the pencil, but we can move the eraser in a circular or complex angular motion. That's circumduction versus the angular flexion and extension. So where we see circumduction within our body, that complete circular movement without rotation, is if we were to draw a circle on the chalkboard with our shoulders. So try taking your arm and moving it in a complete circle. That's circumduction. Rotational movement. We are going to keep the tip of the pencil against your paper. We are going to keep that shaft vertical, but we can still spin the pencil around in a rotating motion. So that's rotational movement. So when we're describing the rotation, once again, it's in reference to anatomical position. So for example, we might have a left or right rotation of the head in reference to our anatomical position. Limb rotation is relative to that longitudinal axis. So we might have medial rotation, which would be internal rotation toward the long axis. So medial rotation versus lateral rotation would be rotation away from that axis. Two specific terms used when we're talking about rotational movement are pronation and supination. So pronation rotates the forearm so that the radius rolls across the ulna and results in the palm facing posteriorly. So pronation, we're going to rotate so our palm faces posteriorly, faces behind us. And then supination turns our palm anteriorly. I'm awful with this camera, I apologize. Our forearm is normally supinated in anatomical position. Remember, in anatomical position, we're standing with our arms at our sides, palms facing forward. So we're normally in supination during anatomical position. And remember, one way you can think of that is you could hold a cup of soup in your hand when you're supinating. When you're pronating, you're pouring your soup out. Some special movements that we can have at synovial joints. Movement of the foot medially and laterally. Inversion is going to be twisting the sole of your foot medially. If this was my foot, inversion is going to be twisting the sole medially, eversion laterally. Dorsiflexion is going to be flexion at the ankle, lifting your toes up. So if this is my foot and I'm lifting my toes up, that's dorsiflexion. Plantar flexion is extension at the ankle. So if you're standing on tiptoe or pointing your toes, that's plantar flexion. And we can also use the terms flexion and extension at the ankle as well. Opposition is movement of the thumb towards the palm or other fingers. So this is opposition of the thumb. And that's what allows us to grab things. And then reposition would be the opposite of opposition, putting our thumb back. Protraction is anterior movement in a horizontal plane, so forward movement. So jetting your chin outward would be protraction. And then the opposite of that is going to be retraction, retracting your jaw to normal position. So protraction, retraction. Depression is going to be moving a structure inferiorly, meaning moving it down towards our feet. So opening your mouth is depressing that mandible. And then elevation, we're moving a structure superiorly or up. So closing our mouth and then shrugging your shoulders is another example of elevation. And then we can have lateral flexion, is bending our vertebral column to the side. That feels kind of good, actually. Sometimes I think we should turn this into a yoga class. Too bad we can't be together. in person to do this. So we also classify the synovial joints by the structure of their articular surfaces. So remember, the articular surface, the surface of the bone on bone. So we have plane or gliding, hinge, condylar, saddle, pivot, and ball and socket joints based on this classification scheme. So our plane joints or gliding joints are joints that have flattened or slightly curved surfaces that slide across each other with that gliding movement. It's a very slight movement. Examples of this we've mentioned before, those intercarpal bones between the bones of the wrist, the vertebrocostal joint between the rib and the vertebra, the sacroiliac joint of the pelvis and the sacrum. You can see all of those here. Let's see. So we've got our intercarpal joints would be here, sacroiliac joint, and vertebrocostal joint, and then also the acromioclavicular joint, where the clavicle and the scapula are going to meet. And then the claviculosternal joint, where the clavicle and sternum meet. Hinge joints are joints that allow angular motion in one plane, so monaxial motion. Examples of this would be our elbow joint, our knee joint, our ankle joint, and the interphalangeal joint within your finger, the joint between those finger bones. So the interphalangeal joints, the knee, the elbow, and our ankle. Condylar joints have an oval articular face, which fits into a depression on the opposite surface. So it's like we've got this oval articulation, and then on the opposite side, there's kind of a depression that it fits into. This joint allows for angular biaxial movement, so movement in two planes. And examples of this are the radiocarpal joint, which you can see here within our wrist, where the radius of the forearm meets your wrist. The metacarpophalangeal joint, which is where your fingers are going to exit your hand. So that's actually right here, metacarpophalangeal joint. And then the metatarsophalangeal joint, which is where your toes are exiting your foot. Saddle joints are called saddle joints because they fit together like a rider and a saddle. We've got this concave and convex surfaces that kind of fit together. Like so. And these are angular biaxial joints, movement in two planes. And an example of this is the first carpometacarpal joint, which you can see on the red arrow there, which is the base of your thumb right here. So we can move this way, we can move this way. I guess that's why I have Batman up here too. Think of saddle joint, we've got Batman giving the thumbs up. The pivot joint, have to stick the pivot meme in here from Friends. So the pivot joint, it allows for monoaxial rotation. So rotational movement, remember? That pencil just spinning, rotating back and forth without angular motion. The atlantoaxial joint is where the skull fits onto the spine, and this allows us to turn our head, and that is an example of a pivot joint. The proximal radioulnar joint, where the ulna in the forearm touches the radius near the wrist, is another example, and you can see that. It's actually right here where the radioulnar joint, the ulnar, sorry, it's been a long night. the ulna in the forearm touches the radius here, so right in here. So it allows for rotational movement. And that's one of the movements that's messed up in my wrist with a limited range of motion. Big one though to think about is the atlantoaxial joint at the top of our skull, of our spine. That allows the head to pivot, and hopefully in lab you'll be looking at the atlas and the axis, which are the first two cervical vertebrae. You can see them here in this image, but they have a very special shape that allows them to fit together. The axis is the more inferior of the joints, and you can see it's got this little protrusion called the dens, and then the atlas kind of like sits on top of it, and then the atlas can, let's pretend this is the dens here, and then the atlas can pivot around that dens of the axis, allowing for us to rotate our head. And then our ball and socket joint. The ball and socket joint is going to allow for angular movement, circumduction, rotation as well, and it is allowing for movement in a triaxial plane, so all three of those planes of motion. So these are going to be our most mobile joints, and we find this in the shoulder and the hip. So here we go again, my favorite part of the chapter. We got to talk about what happens when we get old. So as we age, and we mentioned this a little bit in chapter 6, the effects on the bones as we age, the bone mass is going to decrease. Those bones are going to weaken, and our risk of fracture increases. Degenerative changes in the joints can result in joint immobilization, which means those joints are not moving as much or at all. And this immobilization of joints, this reduction in movement, reduces the flow of synovial fluid. For synovial fluid to be produced, those joints need to be moving. We need that motion within the joint to stimulate production of the synovial fluid. So if we don't have motion, then that synovial fluid is not produced adequately. And then the cartilage degenerates, because remember, the cartilage gets its nutrients and gets rid of its waste through that synovial fluid moving in and out of it. And so if we don't have that synovial fluid being produced as much, and we don't have the movement of the fluid in and out of that cartilage that acts like a sponge, then the cartilage is going to degenerate because it's not getting the nutrients that it needs. And when we have this occur, we can end up with symptoms of arthritis. This can be treated or tried to be prevented by continuous passive motion or passive range of motion exercises of an injured joint. And so that's something like where we went to physical therapists use this. We don't say a joint or a limb is not strong enough to bear normal weight, but we want to keep that joint moving to keep that synovial fluid circulating. And so we might have them do movements that move the joint around, but don't cause strain or pressure. So it's encouraging repair by improving the circulation of synovial fluid by allowing that movement of the joint without causing an increased stress on the joint. Osteoarthritis, also sometimes called degenerative joint disease or DJD, is a specific form of arthritis that's caused by wear and tear of the joint surfaces, or sometimes we can have genetic factors that affect collagen formation. And this is the kind of arthritis that generally affects older individuals, usually people over age 60. And we do see arthritis in 25% of women and about 15% of men as they age. Rheumatoid arthritis is an inflammatory condition affecting far fewer individuals. Women, once again, also predisposed more than men. You'll find in this class not only what a drag it is getting old, but also that women get the short end of the stick when it comes to age-related changes in the body and many diseases. So rheumatoid arthritis is an autoimmune disease. So with autoimmune diseases, that's when our immune system is not recognizing our own body as ourself, and so attacks it. It thinks some part of our own self is an invader, and so our own immune system starts attacking our body. And with rheumatoid arthritis, the immune system starts to attack the tissues within the joint, and so that causes inflammation within the joint. Gouty arthritis is a form of arthritis where we get crystals of uric acid that form within the synovial fluid and interfere with the movement of the joints. You can imagine, think about if you had little crystals within your joint capsule between those articular surfaces cannot be comfortable. This can be due to a metabolic disease. Gout, you've probably heard of, causes a uric acid buildup because uric acid is a metabolic waste product. But we can also see it in elderly individuals, and the cause for that is unknown.